Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts.
Hi everyone who's listening in to the latest episode of the Liver Foundation podcast, or otherwise known as the Liver Lounge. I'm Dr. Margaret Ting. I'm a consultant from the National University Health System in Singapore. And I have here with me today Dr. Dina Mansour. She is consultant at the Queen Elizabeth Hospital, senior clinical lecturer at the Newcastle University, and she's also the secretary of the liver section of the British Society of Gastroenterology. Now, she's had a really recent publication. She was first author of the BSG Best Practice Guidance Outpatient Management of Cirrhosis, and there are three parts to this. There's compensated cirrhosis, decompensated cirrhosis, as well as some special circumstances. So I think here we're very, very privileged and fortunate to have her here to discuss these guidelines briefly. So hi, Dr. Dina, and it's great to have you here.
Hi, thank you for having me.
Yeah. So maybe we just start the ball rolling by asking, maybe you can give us a perspective from the BSG point of view. What prompted the kind of creation of these guidelines, and what is the intended audience for these guidelines?
Okay, well, actually, it came about, we were discussing in one of the liver section meetings because the osteoporosis guidelines for chronic liver disease had become out of date. And we were just thinking, who actually is going to pick up and read those guidelines? And I think there are a lot of guidelines on certain aspects of managing chronic liver disease, but actually they're not widely used because they're either too specific or they're not aimed at the right kind of audience. And there was the lack of overarching guidelines for managing cirrhosis. The other thing, what we really, our primary aim was to address variations in care and improve overall standards in care. So wherever you look in management of cirrhosis in the UK or elsewhere, there's huge variations. We have a scheme called Getting It Right First Time, which recently did a review of all the gastroenterology and hepatology services in the UK, and they found a huge variation in how patients at risk of chronic liver disease or with chronic liver disease were managed in terms of hepatocellular carcinoma surveillance, in terms of variceal surveillance, the proportion of patients admitted with variceal bleeds versus having their varices diagnosed on surveillance. We only managed to diagnose 1 in 5 HCCs at a time when they can be treated. So there's a lot of variations in care that we wanted to address. There was also quite a few outdated guidelines. So, for example, the BSG guidelines, their last iteration for variceal bleeding doesn't mention beta blockers at all. So we wanted to update some of those things, and we're very fortunate in the UK at the moment to be doing a lot of large multi-centre trials on important aspects of managing cirrhosis. So we've got a trial going on looking at using beta blockers in small varices, the BOP trial. We've recently had the Calibre trial comparing variceal band ligation with beta blockers. We've got the aseptic trial looking at primary prophylaxis of SBP. So there's a lot of things that we're currently working on to find definitive answers. And so this is kind of meant to be a bridge to the more formal guidelines coming out. And finally, we wanted to make something that was really accessible to everyone. So to be useful in tertiary transplant centres, all the way through to small district general hospitals, something that everyone could use with a simple aid memoir to ensure that everyone was getting a certain standard of care.
That's great, and I think the language and the kind of way that the guidelines were written in was certainly very accessible, and I can see like generalists or even advanced nurse practitioners being able to pick up these guidelines and treat cirrhosis patients or deliver the same standard of care as a consultant hepatologist. So well done. And maybe I'll just want to go a bit deeper into certain aspects of these guidelines. I think you mentioned the use of beta blockers in patients with small varices, and I think in your in the guidelines it was mentioned about Bavino 7. I think there's this ongoing debate or discussion because I think Bavino 7 kind of recommends that if there is clinically significant portal hypertension, one can just start beta blockers without doing any kind of gastroscopy for varices screening prior to that. But I think in the guidelines, it kind of mentions that the BSG does not advocate this, and maybe you can, expound a bit more into why would that be? Yeah.
Yeah, I certainly can. And so there were a few areas of contention, and this is definitely one of them, that was tricky to get a consensus on, because some centres are doing that at the moment. So some centres have picked what they decide is clinically significant portal hypertension and are giving beta blockers to all those patients. And it certainly looks like there is some evidence for that, partly from the Prodisky trial and subsequent meta-analysis, which shows there's a mortality benefit from beta blockers. I think the issue is that there's a lot of extrapolation going on. So, for example, in the Prodisky trial, that was based on HVPG measurements of portal hypertension and how they correlate to transient elastography measurements. I don't think we can definitely say that we're sure about that as yet. I think there's also some concerns about overuse of beta blockers. So particularly in the trials, we've had a lot of patients who have not tolerated beta blockers. And so it's hard to know in the real world whether patients are taking the medication at all, or whether they're just not getting the side effects. It's odd that we have such a high dropout rate, and I think we're maybe underestimating the side effects of beta blockers. In addition, there's concerns that if you start them too early, then it might put people off treatment later on. So I think there are issues around the use of the Bavino 7 criteria, and that's why we've stuck with, whilst we're waiting for the results of the BOP trial and further analysis, with the Bavino 6 criteria, which allows you to reduce the number of endoscopies that you do based on transient elastography and platelet count, whilst still advocating that you do endoscopies to demonstrate the presence of varices prior to starting beta blockers in most cases.
Oh, great. That's a really good explanation, and I think it will be a debate that will carry on for some time until further evidence is produced on this matter. Can I just ask also, what would your take be? I think there's a brief mention on the use of beta blockers in refractory ascites is not contraindicated, but how would you manage a patient who is developing refractory ascites and also starting to develop a bit of HRS-CKD? I think we have seen a lot of these phenotype of patients. Would you stop their beta blockers, and when would you stop their beta blockers?
So I think it's very difficult. And again, I think we need to continue gathering evidence on this. I think that in most patients with decompensated disease, you can still use beta blockers, but the more advanced their disease is, the lower and slower you have to go with beta blockers. So in patients with advanced disease with ascites or refractory ascites, then I would start very low doses and not try and go too high. So for example, 3.125 milligrams of carvedilol, and maybe split the dose. I think with regards to the development of type 2 HRS, I think it's a lot related to their blood pressure, because essentially we're talking about the hemodynamics and perfusion of the kidneys. And so I think particularly if they run a very low blood pressure, I think I would consider stopping the beta blockers. But I don't think refractory ascites in itself is a contraindication to the use of beta blockers. I think they just have to be used much more carefully and under those circumstances.
Okay, that's a great answer. And I think moving on to the topic of ascites, I mean, I wish I could, discuss this topic of beta blockers forever, but I think we have a bit of limited time, so maybe we'll ask you about certain other topics, or hot controversial topics in cirrhosis. So I think in ascites, I think something that has been coming up on the horizon for treatment is that of indwelling abdominal drains and the use of alpha pump. Can I just ask, I mean, locally for our center, I mean, we do a lot of, for patients with refractory ascites, we do a lot of large volume paracentesis because we don't have the expertise or the equipment available for these procedures. Can I ask about your experience with indwelling abdominal drains in patients with refractory ascites?
So We do have, in the UK, we have an ongoing trial at the moment, the REDUCE-2 trial, looking to compare a repeated large volume paracentesis with indwelling abdominal drains. And we're trying to encourage people to enter that trial rather than using them outside the trial. But we do use them in selected cases. And for some people, they can be really, really important in helping them avoid hospital attendances as they become more frail. We've had pretty good success in palliating patients who really don't want to come back to the hospital. They come in for a one-off radiology appointment when they have quite a large volume of ascites, so it's important that you time it so that they've got plenty of ascites, and then the drain is placed, and then they are able to return home, and then the district nurses, so the community nurses, can go out and empty their drains as often as needed. Often it's a couple of times a week. They only drain a couple of litres, so there's no albumin required, and it does save on the patients travelling to and from hospital. Now, again, there are issues, an increased risk of infection is one of the major theoretical risks. We haven't seen, in the ones that we've used, we haven't seen a huge difference in the infection rates between repeated large volume paracentesis and indwelling drains. We've had a few cases where patients have unexpectedly recompensated, and we've had to take the drains out because they no longer have ascites. So you do have to be careful about who you use them in. But certainly patients who are dying and find it very, very difficult to come into hospital. I think one of the other things that we can sometimes underestimate, though, is the value of patients. Some patients coming into hospital and having that interaction, the chance to talk to the nurses, because we do all our paracentesis as day cases with the liver nurses who they know very well, and it provides them with some company for those patients who live alone, and so sometimes it's quite nice for them to come into hospital, and some of them enjoy it, but for some patients it's definitely the right thing to do, and we haven't seen any worrying complications, but we're waiting really before we start using it more routinely for the results of that REDUCE-2 trial.
Oh, that's great. I think we'll eagerly await the results of that trial, and hopefully that will become practice internationally once the results are out and definitive. Okay, so I think we talked about varices screening as well as paracentesis and drain insertions. I think for cirrhosis patients undergoing procedures, I think the other debate that has been going on is the value and utility of platelets and INR for yourself. So I have a few questions here for yourself. What would the recommended platelet count be prior to an elective procedure, like not in an emergent bleeding situation, in terms of for the gastroscopy? And I guess the second point is, second question would be, would the use of ROTEM or one of those thromboelastography tests, would they be something that is commonplace, or do you think that we're moving in that direction?
So I think this is a bone of contention between us and our radiology colleagues a lot, and I think a lot of places do struggle with differences in protocols between hepatology services and, for example, radiology services. The evidence is that particularly in procedures which are low reading, so less than 1.5% risk of bleeding, and that would include things like gastroscopy, paracentesis, even liver biopsy, there's no need to even check the clotting or the platelet count, and there is no platelet count that is unsafe. That giving platelets to increase the platelet count can actually increase portal hypertension, which is the main cause of bleeding in these patients. And so actually, perversely, you can increase the risk of bleeding by giving them platelets. Some of the newer medications to increase the platelet count that you mentioned can be useful in elective procedures in patients who, for example, have a platelet count of less than 50. And if you can plan the procedure and get their platelet count up over a period of time. But for most procedures, it is not necessary or desirable. I think for in terms of the measuring the bleeding risk, the tag that you mentioned again that can be used in surgery, but the main evidence for that is reducing the need for blood products, because, as we know, the platelet count and the clotting in patients with cirrhosis does not at all reflect their bleeding risk, and actually most of them are prothrombotic, not procoagulant.
Okay, so I think maybe moving on, I think we've talked quite a bit about the decompensating events of cirrhosis. Maybe we will talk a bit more about the general management of outpatient management of cirrhosis. I think what I was very impressed about, or something that was good in the guidelines, was that there was some recommendations in terms of nutrition, osteoporosis, alcohol use, etc. And I think this is not something that, as you mentioned, they are usually scattered across various guidelines and not in one place. So in terms of these, and you also mentioned previously that there are liver nurses and there are nurse practitioners. I would want to ask a few things. So number one, how would your cirrhosis service function in terms of do you have a dedicated nurse practitioner, and how important is the role of allied health professionals in the management of outpatient management of cirrhosis?
Yeah, so they're hugely important. I think particularly having specialist liver nurses, it makes a massive difference to the patients, particularly those who are decompensated. So, for example, we have a decompensated nurse-led clinic, which combines the day case paracentesis with an early discharge clinic for patients who have recently been discharged, so they can all be seen within 2 weeks of discharge from hospital if they come in decompensated, and also those who need close monitoring, either to titrate diuretics or to manage fragile encephalopathy, or those we've even used, for example, ambulatory albumin in some cases as a bridge to transplant or for palliation. Building up a rapport with the liver nurses means that patients can be much more easily palliated at home if they're not suitable for transplant. Having easy access by phone to medical advice, easy access to paracentesis means patients don't wait as long for paracentesis, and that has a huge knock-on effect to their ability to eat and maintain their nutrition. I think we are very bad in general at focusing on patients' nutrition, particularly those with decompensated cirrhosis, because it's a huge factor in determining both survival, quality of life, transplant outcomes, ability to get to transplant, and I think it's something that we should definitely concentrate on more. I think a lot of centres struggle in that they don't have enough dietitian and certainly physiotherapy input, and I think in that case it's beholden on us to understand more about nutrition so that we can give advice and assess our patients' nutrition more accurately. And I think some of the specific liver tools like the Royal Free liver frailty index, the Duke's frailty index, those kinds of things can definitely help us assess who to target, who needs dietitian input, and also who may need things like supplements, even in enteral feeding. Again, you have to individualize it to each patient. There's another great trial going on based in Birmingham called the EXALT trial, looking at giving patients a home regime for resistance exercises prior to transplant and looking at the difference that makes in outcome. And I think we need more of those and more focusing on a holistic approach to the management of patients with liver disease. And I think for that kind of thing, allied health professionals are hugely important, and we need to try and expand our liver teams to include them. And the economic case is quite easy to make, because if you can improve patients' nutrition and overall well-being, you reduce the risk of coming into hospital, which is extremely expensive, as well as improving mortality and quality of life.
Thanks a lot for that nice answer. I think locally for us, I think we still have some work to get there, but I think it's the UK has probably a very good model to follow, and I think in your guidelines you also provide very nice algorithms or like care bundles. So maybe I just want to ask about these. What would the purpose, or how should these care bundles be used? Would they be for these, as you mentioned, nurse-led clinics?
Well, I think they can be useful for anyone. I think in the past, one of the issues has been that, particularly with patients with stable cirrhosis, they're seen as quite a quick clinic appointment because often they don't have a lot in the way of specific symptoms. Then if they're not decompensated, there doesn't seem to be a huge amount to do, but actually there's a lot of things that we should be doing to try and ensure that they remain well, and that would be much better than waiting until they were decompensated. So things like that are so important, like checking they've had their vaccinations. So the relative risk of mortality for a patient with cirrhosis from flu is about 50 times more likely to die from flu than a healthy person. That is the highest risk of any high risk group, so higher than risk of patients on immunosuppression or chemotherapy. So making sure they've had their flu vaccinations is hugely important in preventing morbidity and mortality. Things like focusing on their nutrition, really focusing on management of the underlying etiology, and particularly alcohol, which again we don't do very well, and ensuring they have the support they need to manage that, making sure that we properly do HCC surveillance diligently. And again, that's something that we think we do very well, but recent data from the US indicates, and any time there's been a study, show that we do it very, very poorly indeed. So focusing on all these things, making sure they don't come in with their fractures, which is another thing that they often present acutely with, because we've done adequate osteoporosis screening and surveillance. I think these things can be easily missed because there's actually quite a lot to think about. And so the care bundles are there as an aid memoir to make sure you're not missing things, and to try and standardize how patients are managed. And similarly with the decompensated cirrhotics, you can go down a rabbit hole of focusing on just one area, and this just helps to maintain a more holistic approach and make sure you really manage all aspects of their care. It's intended to be used in outpatients, so either as a paper version. A lot of places now have electronic patient records, so that can be uploaded, so that instead of doing a clinic letter, you can fill in the various fields, and then there's a blank space to free text, and then that can be communicated to the GP. If you have it on paper, you can also have all the guidelines on the back with the algorithms for varicose and osteoporosis surveillance, for example. So it's up to individual places how they want to use it, but we just hope to provide some support with standardizing that management, whether it's nurse-led clinics or consultant-led clinics.
It's a great, actually, this is a really great and useful checklist. And I think even for us, although we've been seeing cirrhosis patients for a number of years now, sometimes we forget, especially as you mentioned, things like osteoporosis, vaccinations in a busy clinic consult, we would tend to forget these. And I think earlier you were talking a little bit about nutrition. Of late, the more common etiology of liver disease would be, what they recently renamed it MESL, or metabolic associated steatotic liver disease. So I think there was a brief mention in the guidelines as well, but in these patients with MESL related cirrhosis, they tend to be overweight, but yet they are sarcopenic. And I think the challenge that we have is that, the treatment of MESL is to kind of ask our patients to lose weight, but at the same time, we need to balance that against the risk of sarcopenia and muscle loss in muscle mass. And I think the guidelines did mention something about having a slower, more sustained kind of weight loss regimen. Maybe you could comment a bit about this. And also, I think the Aspen guidelines also generally recommends that in patients with cirrhosis, they should get nighttime oral nutrition supplements to reduce the risk of or to reduce muscle breakdown and catabolism. But I think in these patients who are already overweight, they may not benefit from these additional supplements. So perhaps you could comment a little bit about these 2 points.
Yeah, I mean, yeah, of course. I mean, it's really, really difficult, isn't it? And we've all felt the challenge of that in patients who are overweight with sarcopenic obesity, particularly those who have cirrhosis. I think once patients decompensate, they tend to lose weight anyway. So they can lose significant amounts of weight, even if their underlying diagnosis is MASLD. I think for the patients with compensated cirrhosis, you can still definitely get them to lose weight safely. But really, it should be under the supervision of a dietitian because it is so complicated. So my first advice would be try and get your dietitians involved. Now, we have a problem with that because our dietitians do not do weight control. So we have no weight loss service dietitians. So they often refuse to see them, which isn't helpful at all. But I think in terms of general advice, a gradual weight loss is far preferable to any to rapid weight loss. About a minus 500 calorie deficit, 500 calorie deficit has been found to be safe in patients with MASLD related cirrhosis. So you can aim for about that. It needs to be in terms of managing their intake, you can switch them from more high sugar, high carb kind of diets to higher protein diets. And so, for example, for the nighttime snacks, instead of having something that's high in carbohydrates, they can switch to have something more protein based or something like eggs, or so that it's not increasing their insulin resistance and maintaining the high level of insulin, which is one of the problems in MASLD, the underlying problem of insulin resistance, whilst preventing them going into a catabolic state that's going to reduce their muscle mass. And obviously combining that with resistance exercise to improve their muscle strength and reduce sarcopenia will help with the sarcopenic aspect of obesity. But it is very, very difficult, and really we should be having help from our dietitians and physiotherapists in managing these patients.
Yeah, indeed. I think as you mentioned, sometimes it's a bit challenging, especially for those like liver focused dietitians, because they may not be trained to kind of deal with improving nutrition, but at the same time weight loss. So I think that's something that the field needs to continue to evolve in. So I think we've mentioned having a nurse, in a liver specialist nurse, and a dietitian and a physiotherapist. And maybe the last point that we should discuss is also, is there any role of social worker, psychologists, and what would the role of palliative hepatology be? I think this is something that has been increasingly focused on, like even for pre-transplant patients, even if they're being planned for a transplant, there's a shift towards thinking about introducing this concept to them earlier, to such patients earlier. I think this was briefly mentioned or briefly touched upon in the guidelines. And can I just ask, in your experience or in where you practice, is that something that is being commonly done, and how can we encourage the involvement of advanced care planning, or like professionals who help with advanced care planning in these patients?
Yeah, so I think that's a really important issue, and again, something that traditionally we've done very, very badly. So the rates of patients with liver disease dying in hospital is extremely high compared to, say, patients with end-stage cancer. And a lot of that is because, part of that is because of the really difficult nature of the trajectory of liver disease, whereby patients have decompensations and then can improve and recompensate and then decompensate, and then one of them will be their final decompensation, but it's hard to know exactly which one it's going to be. And I think and we've suffered from them falling between two stools in some ways. So palliative care specialists don't feel particularly comfortable with dealing with liver disease, and liver disease specialists don't feel particularly comfortable in dealing with palliative care. So I think there's a number of ways that we can improve that. I think one of the important ways that we can do it is to collaborate more with palliative care colleagues, and quite a good way of doing that we've found is setting up advanced liver MDTs. So patients who are decompensated are discussed in an MDT format with liver nurses, hepatologists, gastroenterologists, and palliative care specialists. It's really important to get community involved. So we often ask for patients who are decompensated to be added to the palliative care register in primary care, and that means that they have access to district nurse support and palliative care in the community. They can also be put in touch with things like social prescribers, which is a concept by which there are these people who are not medically trained, but who act on behalf of patients to work out what benefits they're entitled to and support them to get those benefits. And they can be hugely important because liver disease, as we know, disproportionately affects disadvantaged people. And there are all kinds of things that go along with that make managing advanced liver disease far more difficult. For example, they often can't afford to eat as much as we suggest they should eat, and they can't afford care in the later stages of their life. So ensuring that they have all the help and support they need is really, really crucial in helping them to manage their disease in the way that they want, to give them some autonomy. If they want to die at home, there are ways to try and ensure that that can happen, although it is more difficult in liver disease because of the trajectory, like we said. So I think that there's a lot of work to do, but the main thing is recognizing early and introducing the concept to the patients, including a parallel care, which you alluded to, which is just because you're having palliative care doesn't mean, or supportive care doesn't mean that you can't be actively treated still. So it's making the patients understand that what we mean by palliative or supportive care is managing their symptoms, managing them holistically, whilst also managing their liver disease. And I think once we get to that as a concept, that's a really good starting point for improving the dialogue around it and reducing the patient's fear associated with the concept of palliative care and the health professionals' fear of it as well, and means that we can far more effectively manage the patients in their last year of life.
Thanks a lot for the very comprehensive answer, and also, giving us. This interview was very illuminating for me personally. I think it's very nice to see how another healthcare system functions and how a cirrhosis service is developed in another healthcare system. So thank you very much, Dr. Dina. And is there anything else you would like to tell the listeners of Liver Lounge?
No, just thank you very much for inviting me to speak about these guidelines. I hope that people do find them useful, and it's a pleasure to have been here, so thank you very much.
Thank you, and to the rest of our listeners, thank you, and hope you join us again for the next episode.
We have come to the end of the episode. Thank you for joining us, and stay tuned for more captivating discussions.